In this presentation, we're going to talk about implant-retained removable prosthesis. As we saw before, implant-retained prosthesis can be mainly classified in two categories. One category would be the fixed prosthesis, where the fixed prosthesis has the purpose of replacing the missing teeth, and the second category would be the implants be used as a retained element for either a fixed prosthesis or a removable prosthesis. So in this case, we're going to talk about the role of the implant to increase the retention of dentures or partial dentures for patients that they lost bone due to the fact that they had missing teeth, all edentulous arches. So it's very important to understand that there are different treatment options, both clinical and restorative in this area. We're just gonna touch upon the main categories and describe the procedures, a little bit of the clinical, but mostly of the lab procedures, how we can attain removable prosthesis that has more retention in terms of dentures. So the procedures for implant retain removal prosthesis starts with diagnosis of the patient. So this is the job of the dentist. They look and they take different CAT scan and imaging to evaluate the bone density and the quality of the bone for receiving implants, and deciding also how many implants are needed for the restoration and what type of restoration will be appropriate for the patient. In terms of the number of implants, like we said, it's very important to also understand that sometimes the dentist, they place implants in the area, from the clinical aspect, in the area where the bone is stronger. So sometimes from our perspective, it might not be ideal because, like we said, regarding the path of insertion of the prosthesis, we want the implants to be parallel with each other. Unfortunately, in some cases, this is not doable because of the bone quality. So sometimes the oral surgeon will place implants that are not parallel with each other. But from the restorative perspective, we have different options to compensate for that. And we're going to talk about this later on. So one way to retain a removable prosthesis is to fabricate a bar and clip prosthesis, and this is very much the same principle like a hide bar, where a metal bar was inserted in the patient's mouth, and there the denture will have like retention element processed inside the denture that will grip the bar and provide more retention for the denture. So this is the main, very briefly describing, the role and function of a dentures using a bar and clip. So one popular type of plastic bar and clip attachment for removable prosthesis is called the hide bar. A hide bar is cast into a metal and uses plastic retaining clip that can be easily replaced when necessary. Excuse me. The bar and clip normally uses two implants, usually in one canine area, using a standard abutment, a gold cylinder with a bar connected to the gold cylinders. So when we're talking about gold cylinders, we have to remember that those gold cylinders or gold adapted abutments, those are the UCLA. So we saw in the procedure for casting or fabricating hands-on custom abutments, we use those UCLA or gold adapted abutments to fabricate the custom abutments. The same principle applies here. We can use those UCLA to uh, use in designing the Haida bar. Now, this overview of the Haida bar talks about two implants, but we're going to see later on that actually this can be extended to a larger number of implants. Located inside the resin on the tissue side of the denture, it's a plastic clip that retains the denture when it's seated. So this is the retention element where that clip grabs the bar and snaps in. So it's more like a snap-in prosthesis. So everything starts with fabricating the custom tray. And when we fabricate the custom tray, we have to have a preliminary cast that the dentist took the impression, we put it up in stone, and now we're ready to fabricate the custom tray. Usually, uh, to create a little space for the impression material, a thin layer of base plate wax, it's covering the ridge of the cast, and then um, the tray it's fabricated, and also based in on the preferences of the dentist or the oral surgeon, we can place the holes on the custom tray where the implants are placed or might be placed. All right, so this will be an open tray impression, because especially in cases like this where we're dealing with stability of the future prosthesis and also accuracy of the impression where the implants are located and positioned in the patient's mouth to be transferred to our model, we want to use an open tray for taking an impression. Then we're ready to fabricate the master cast. In some cases, it's indicated to also do the soft tissue if necessary, but in general, for removable overdenture or partial denture, this is not necessary. Um, I would rather have a stone around the implants because the type of abutments that we're using here and also aesthetics are not involved in this case. So we're using the soft tissue when we need to be concerned about aesthetics, like the margin should be subgingival, and also to see if the abutments are seated properly. But that's because the abutments for fixed versus the abutments for removable are different. So in this case, sometimes it's better to not do a soft tissue material and to have stone around the implants. If it's a concern in terms of the properly seating the abutments before putting up the impression into stone, a little bit of wax can be added around the um, analogs or the replica to create a little space. So when we put it up in stone, in our model, we have a little bit of space between the gum and the implant. so we can see if the abutments are seated properly. When the dentist takes the impression for a complete denture, even if we have it's an open tray impression with the implants in and um, the implant copings and the analog inserted, it's recommended to do the model like we do it for dentures, meaning that we have to beat and box the impression. And this is important because by beating the impression, we create a little bit of space, maybe 2-3 millimeters of the border. So we have more visual where the border ends. And this is important because that's where we're going to end our denture. And also, we have to box the impression because that allows us to have a more uniform and stable cast that can be easily mounted. Um, very important when we pour up the impression, we have to be careful to mix the stone, and I recommend in those cases to use dye stone because it's stronger and more accurate, and also use a vibrator to pour up the stone. But again, very careful with the speed of the vibrator because we still have the impression scoping inserted into the impression, so high vibration might dislodge or change the position of the impression copings. So low vibration and pour the stone in such a manner that there is no voids or trap air inside the stone. Then, exactly like the same procedure like we do for dentures, we have to fabricate the base plate and occlusal rim. Now, the only difference regarding the occlusal rim for removable implant prosthesis versus a complete denture is the fact that the occlusal rim in our case will have the attachments or the abutments for the denture embedded in the denture. So if you remember, for complete denture, we do the occlusal rim directly on the ridge, and we adapt the base plate to the ridge to be accurate. Well, because we have implants here, we have to be careful and also to make use of those abutments that we have attached to the replica in the models. So the fabrication of the place plate or and occlusal rim goes like this. The first step is to attach gold cylinders or the UCLA to the abutment replica, and then block out any area that might be an undercut, and make the standard base plate engaging also the denture. When making the occlusal rims, leave the area around the guide pins open to prevent the wax from interfering with the access holes or the pins. To be used successful, record bases should have certain construction characteristics because they are made to cover the identical surfaces as the completed denture cover. So in general, we have to do the occlusal rim at the same specifications as the occlusal rim will be done for complete dentures. There are some exceptions when we're talking about implant retaining prosthesis and fabricating the occlusal rim in terms of um, opening the vertical dimension. So if the doctor require us to open the vertical dimension, maybe we need to add a little more wax on the occlusal rim. But those are very specific cases. So in general, we do the occlusal rim exactly like we did it, the same measurements like we did it for complete dentures. Also very important when we do the occlusal rim to make sure that um, the sulcus it's covered, so the border of the occlusal rim it's ending where the sulcus is, right? So these are the dimensions that we use for the occlusal rim, which are the same for complete dentures and for um, occlusal rim for implant retained overdentures. How we articulate the case, and this is very critical. In general, the best way to articulate a case like this would be to use a Facebook device. And this is device that register a lot of movement of the patients and also establish the centric relation. So it's very important that the doctor takes an accurate Facebook record, and also very important is to um, coordinate with the dentist and use the same type of articulator as they use the Facebook. So each type of articulator, they have their own Facebook. So for instance, if the doctor uses a Jensen articulator, they're going to use a Jason Facebook that works with that articulator. If we don't have a Jason articulator, then we cannot use that, let's say, for a Stratus articulator. So we have to make sure that we are on the same page when it comes with what type of articulator we're going to use, and also the Facebook that the doctor uses to record all the measurements necessary. So after the doctor takes the Facebook record, he's going to send it to us with the case, and we're going to use this to mount the case. Now, it's very important when the Facebook comes to us, we have to keep in mind that this part of the Facebook, the table of the Facebook, actually was inserted in a patient's mouth. So we have to make sure that everything is disinfected before we start working with it. So the Facebook, it's attached to the articulator, and the maxillary cast, it's inserted into the occlusal rim that we receive, and it was placed into the Facebook, and that's how we're going to mount the upper or the maxillary cast. And once the maxillary cast is set, then we can mount the lower cast to the upper cast, and that's going to be pretty accurate. There is another method that can be done using a table, an articulating table, if the doctor doesn't take a Facebook and they take a bite registration. But that it's not very accurate, and it's a little bit more complicated. Um, Also, we have to make sure when we use the face bow, after the insertion of the face bow into the articulator, we have to make sure that all the tools regarding the condylar inclination, all the knobs in the back are tied up, so nothing moves during our articulation. So this is how an occlusal rim looks when it comes to us from the dentist. We have the measurements that are needed for us to work on the case, and it's very important when we do also the mounting to not kind of destroy or in any way interfere with the measurements. Don't forget the occlusal rims are in wax. So the more we put our hands on the wax or we play with um, the wax, the occlusal rims, the more chances we have that those marks that the dentist made for our measurements, they might be distorted. So very careful. The mounting should be done very careful. And also when we mount the lower to the upper, we have to make sure that we insert the pin in the articulator and the pin is set up in that position and is not moved anymore after the mounting is done. Important, of course, is that the pin is touching the table. If the pin is open, that means we open up the vertical dimension for the patient. So when we're gonna do the final restoration and it's time for the dentist to insert the final restoration, that's gonna interfere with the bite and the patient will not be able to close their mouth. So very important, always keep the pin at the position that was doing the mounting. Then we can use, after we have the case mounted, we can proceed with ordering the teeth that we need, the denture teeth, and setting up the teeth exactly like we'll do with a complete denture. Um, Again, this is very important because we have to make sure that the occlusal um, contacts and also the centric relation is correct, the vertical dimension is correct. And once we have everything set up in wax, this is set up to send out to the dentist for a try-in. So another way to ensure that during this time, when we set up the teeth or when we fabricate the try-in denture, that we have the model, the master casts done properly, and also the location and position of the abutments are correct, exactly how they are in the patient's mouth. This is the time where we can use a verification jig. So many times at this stage, the dentist might ask us to do a verification jig, and that verification jig is sent in with a trial denture. So the doctors try the denture first. If everything fits, if the abutments fits over the patient's implants, everything is fine, there is no problem, that's perfect. But if there are any differences in how our denture fits in the abutments in the model versus how it doesn't fit in the patient's mouth, that's a problem. So using that verification jig, the doctor can establish if the position of the abutments in the master cast that we do are different from what the patient has, and this is the time to correct that. So once we have the case mounted, it's for us, the next step will be to fabricate the bar. This procedure, it's a sensitive procedure because we have to be careful at many aspects of designing the bar, but also this is a hands-on procedure. The materials that we are used for casting the bars usually are base metals. So unless the patient has an allergic reaction to those base metals, the bar can be fabricated using semi-precious, maybe dental alloy, but those are very few cases. So to fabricate the bar using the hands-on method, we start first by attaching those UCLA or gold cylinder to the master cast and tighten it up using the guide pins or the long pins. Then we're gonna cut a piece of the plastic bar to fit between the gold cylinder. So this piece of plastic bar, usually they come prefabricated, and it's important to understand that this plastic bar that we're gonna use has a certain design. And if we look at those pictures presented here, we can see that the top of the bar, the top surface of the bar, it's more rounded than the rest of the bar. So that's done on purpose because that's the retention element. That where the clip is gonna snap in, right? So it has to have the bar has to have an undercut for the clip to be retentive, right? Keep the plastic bar straight to allow for easy sitting on the clip. Position the plastic bar at a minimum 2 millimeters above the tissue for allowing for easy cleaning. So this is for allowing for hygiene. So the patient can clean between the bar and the gums, all right? So this is very important. We never sit the bar on the tissue. There is always a little bit of space because the patient has to use a Prosy brush or other form of um, cleaning or hygiene tools to keep that area clean. Attach to the gold cylinder with the inlay wax. So this is the part where we're gonna add wax to attach or to connect the plastic bar with the gold cylinders. All right, and then we're gonna sprue invest in and cast the bar using the lost wax method. Okay, once we have the bar fabricated in metal, now it's time to polish, and this is very important. Everything has to be nice and smooth, no sharp edges, especially if there are areas where it's touching the patient's gum. We want everything to be nice and smooth and very well polished. Why we want it polished? You might think that, oh, it's under the denture, nobody sees it. Why we need to polish it so well? We need to polish it because We don't want any food or bacteria to get stuck on the surface of the bar if the bar is rough and not very smooth and well polished. So as we see in picture M, the bar is fabricated, it's inserted into the model, it's screwed in into the model, it's tied in there, and then the clip, it's inserted to see the retention, to see how well we did the bar, and if the bar has a good grip on, if the clip has a good grip on the bar. The next step will be to process the denture, and when we process the denture, we embed the, the clip into the denture, and the clip will be processed inside the denture. Okay, so this is roughly and briefly the description of the procedure for fabricating the bar and also for attaching the clip to the dentures. Like I said, there are many different type of bar designs. This is the most simple and straightforward design, but we can have design a bar that goes through the length of the ridge, and also it's more complicated when we have a cantilever portion, especially on the posteriors. So today, when we're talking about restorations that have large span cantilevers, we want to provide support for the cantilever, and that can be done with extending the bar behind those two abutments that we have. So in terms of the design of the bar, what we presented here is just like the simplest form, but like I said, there are many other considerations to take place in terms of the design. Mainly, the main concern will be the long span of the cantilever of the prosthesis. And again, it could be a fixed prosthesis or removable prosthesis. The cantilever always presents a problem for us. How we ensure that the prosthesis is stable in that area where, especially in the posterior area, where the forces are greater. Treatment options for mandibular implant overdentures. The placement of the implant enhances the support, retention, and stability of the overdentures. What are the advantages? Minimum anterior bone loss prevents the bone loss. So once we have an implant inserted into the bone, that stimulates the bone growth through the osseointegration process, but also prevents further bone loss. Okay, it's improving aesthetics, improves stability because it reduces or eliminates the prosthesis movement, and uh, especially for patients that are wearing complete denture or partial dentures, because the bone constantly shrinks, right? The dentures always have a movement. So by adding those retentive elements like the bar, the denture is more stable. So therefore there is no movement of the denture, or it's very minimal. Improve occlusion. So it's very easy now because um, the bar also gives us a stable occlusal plane. So to achieve a centric relationship, it's much easier when the occlusal plane is well established and defined. Decrease the soft tissue abrasion, and this is very important. Many patients complain, and rightly so, that they have sore spots on their gum because of the denture moves. So when they eat, the denture has a little bit of movement, and that creates, even though the denture it's smooth inside, there is no rough edges, it still sometimes creates sore spots on the tissue. So because our denture, implant-retained overdenture, it's more stable, and therefore there is no movement, that eliminates or reduce the sores on the gum. Improve chewing efficacy and force, increase occlusal efficiency, improve retention, improve support, improve speech, reduce prosthesis sizes. Especially that's important for maxillary. If you think about it, when we do a complete denture, one of the retentive element of the complete denture for maxillary is the palate, right? Because the palate, on the palate we have the occlusal, the post dam, right? So the post dam creates a vacuum-like suction, so that keeps the denture in. Now, in our case, because our denture it's supported by the implants, we don't need the post dam. Therefore, we don't need the palate. So we can eliminate the palate on the denture, and that improves greatly the efficiency of patient chewing, speaking, and tasting. So many patients are happy they can taste the food better. And improve the maxillofacial prosthesis. So sometimes when we design a denture, sometimes we have to meet certain parameters in terms of the thickness of the denture. So in some cases for implant retain overdenture, that can be simplified, can be reduced. What are some advantages of overdenture versus fixed? There are fewer implants, less bone graft because everything gets retented through the bar, improve aesthetics. The fact that we can use denture teeth, so it's in a way easier and faster to fabricate, and also we can make the transition between the teeth and the gum much nicer, looking more natural. If you think about the fixed prosthesis, when the bone resorbs, also the gum resorbs. So sometimes there is a space between the fixed prosthesis and the gum itself. So in those cases, we use pink porcelain to compensate for that. Well, in overdenture, that's not necessary. Hygiene is improved. Also, the force, the bite force, it's different distributed. So because the bar gives more stability to the prosthesis, therefore, when the patient bites down, the biomechanics of the prosthesis is improved also. Low cost um, for the patients and for the laboratory, because we're using materials that are not so expensive, and also um, we can use a temporary restoration that can be very close with what the patient is going to wear for the final restoration. So the patient gets used to using this type of restoration uh, before the final restoration is inserted. For mandibular implant um, overdenture, there are some disadvantages. Um, the fact that for the mandibular overdenture wears out faster, okay? So therefore, um, that may be a little bit of expense, because they sometimes that overdenture, mandibular overdenture, has to be redone. Attachments such as O-ring or clips, they wear fast and they must be changed regularly. So as a rule, those clips are plastic or silicone based, and depending on the strength of the clip or the the ring, they have to be changed once a year, okay, because they wear up pretty fast. Denture teeth were faster than fixed restorations. In the fixed restoration, we're talking about zirconia, which most of the cases, which is a very strong material, versus denture teeth, which are plastic, right, acrylic. A new overdenture is often required at 7-year increments because of denture teeth wear and soft tissue changes. And that's true. The soft tissue always reserves or shrinks, leaving more space between the denture and the bar. So the overdenture needs to be redone. As a side effect of mandibular overdenture, it's food impactation. So this area where the gum resorbs, right, and it creates a space between the bar and the denture. That's where the food gets impacted. So this is very hard for the patients to clean. The flanges of the prosthesis do not extend to the floor of the mouth in the rest position. So that creates a little problem in terms that this is how the food gets underneath the prosthesis. If the prosthesis will be all the way into the sulcus, right, all the way into the floor of the mouth, then the food wouldn't have a path to go under the denture. But because that's cut short, the chances of the food getting underneath the denture are greater. A similar condition is found with the traditional dentures. However, because the lower denture floats during function, the food more readily goes under and out, whereas the implant overdenture traps the food debris against the implant bars and attachment. So again, when we design the bar or the attachments for an implant retained overdenture, always we have to keep in mind in the design how we can design this prosthesis, in keeping in mind that the patient has to be able to clean. All right. The posterior bone resorbs faster than an anterior bone. An implant prosthesis with posterior soft tissue support might accelerate the bone resorption 2 to 3 times faster than in a complete denture. The mandibular overdenture required at least 12 millimeters between the soft tissue and the occlusal plane to provide sufficient space. 15 millimeters from the bone level to occlusal plane for the bar attachments and teeth. So we see now from restorative point of view that there are certain requirements that we have to meet in terms of parameters, right? So dimensions. So we need to have at least 12 millimeter from the gum to the occlusal plane to allow for the bar and also for the prosthesis, for the dentures. All right. And that's why sometimes if there is a issue with those measurements, the required measurements, the dentist might ask us to increase the vertical dimensions to meet those requirements. Overdenture movement may occur in one of six directions of plane or planes: occlusal, gingival, facial, lingual, mesial, and distal. So this is how the overdenture might move. Now, like I said before, the movement of implant-retained overdentures, it's limited when we're using a bar because that creates more stability for the overdenture. But there are cases where this movement can be amplified, so to speak. So a classification of the prosthesis movement: PM0, where there is no movement; PM2, the prosthesis has hinge motion, opening and closing; PM3, the prosthesis has a hinge and apical movement, down movement; PM4, the prosthesis is moving in 4 directions; and PM6, the prosthesis is moving in all directions. Based on overdenture movement, the doctor have different options for placing implants, such as location, anterior and/or posterior, and the number of implants, minimum 2. All these factors influences the selection of prosthesis and how the dental technician designs and fabricates the overdentures, especially the bar design. So these are some treatment options for mandibular implant overdentures. So when we have an overdenture that has the 2 implant and anterior position, and we see here in the picture, and this is exactly what we were talking about, the hide bar, where we have the bar inserted in the patient's mouth in the anterior position, and the bar it's retained by 2 implants, right? So the bar are splinted together with the rigid bar without any distal cantilever of the bar. When 2 implants are connected together with a cantilever, the prosthesis has less movement, and movement forces are increased on the abutment screw, implants, and bone. So you see how important it is in the design, because now the movement transfer force where we don't really need it into the abutment screws, implants, into the bone. A cantilever hard bar in this patient results in the prosthesis movement of 0, which is much too rigid for the 2 implants. In a vertical dimension, the bar should be more than 2 millimeters away from the soft tissue to provide easy access for the cleaning. So if we look at the first picture with the bar inserted into the patient's mouth, we see that there is a gap between the bar and the gum. So that allows for the patients to clean. The bar position might be achieved more easily by selection of the proper height implant abutment. The connecting bar of the restoration should be fabricated after the final contours and teeth positions are developed for the overdenture. otherwise compromises the inadequate room for denture teeth or over-contour restoration, most over on the lingual surface result. When the crown height distance is reduced, a hide bar and clip might be used. So in other words, if we have small denture teeth, right, and we have more room, we can use a bar that allows us to um, meet the vertical dimension, the natural vertical dimension of the patient. The bar should be parallel to the plane of occlusion and perpendicular to the midline. Also, the bar is often placed to the facial of the implants to reduce the height requirement and to reduce the lingual contour of the prosthesis. Especially on the mandibular, we want the lingual contour of the denture to be kept to a minimum because that interferes with the tongue movement. For the 3 implant options, placed anteriorly, right? 3 implants provide sufficient implant support to permit the attachments to be placed on the distal aspect of the implants. This option most often is considered when crown height dimension is reduced. No cantilever of the bar should be designed with this 3 implant system because it puts too much stress on the implants itself. The clip attachment is designed for the prosthesis. The bar might connect the facial of the implant's copings to the lingual of the coping. As a result, a straight bar might be fabricated perpendicular to the path of rotation. So in other words, it's very important that the abutments that are done to be parallel to each other, but also the bar should be parallel to the gum and perpendicular to the path of rotation, how the denture wants to move. 2 hide bar clips and bar should not be angled towards each other because that changes the parallelism and the path of insertion. The rotation of one clip is limited by the other, and this results in no movement or PM0. The case where we have mandibular overdenture that has 4 implants, and those implants are placed anterior and also sometimes on either the canine area or the first premolar area. The primary advantage of this treatment is the ability to cantilever a connecting bar up to 10 millimeters on each side if stress factors are minimal. So in other words, if we have a larger area of cantilever, 4 implants placed this way will give us more stability for the cantilever portion of the denture. The bar is often cantilevered distally up to 1.5 times the anterior posterior distance. So depending on the force factor and of the patient condition. So sometimes we have patients that they have a strong bite or they have bruxism, and we have to be careful to maintain that distance posteriorly on the bar. The cantilever from the most distal implants expand to the last occurrent tooth and not the end of the bar. 4 implants are usually insufficient to support a full arch fixed prosthesis where we have no movement, all right? Treatment, another option would be a mandibular overdenture that has 5 implants, and the bar is designed to provide prosthesis that has a cantilever that is 2.5 times the anterior posterior distance. And that means that it's a longer cantilever space. And um, this has many benefits in terms of it makes the prosthesis more stable and also eliminate or reduces the bone loss in the mandibule, because now you have something that is inserted in the bone and that induces the osseointegration process. Um, so um, the mandibular implant overdenture design and fabrication using the Hyder bar and clip. And these pictures, we can see very well how this works. So the Hyder bar clips works with a metal encapsulator. So that metal piece, that's the one that is the clip, and that's the one that is processed into the denture. Then we have that plastic um, element, that's the retention element, and that's what's grabbing the bar. So that plastic element, it's the one that allows the denture to have a little bit of movement. And the clips, they have 3 different retention strengths and up to 20-degree clip rotation, which greatly improve the flexibility of the system for a range of patients' needs and desire. Okay, so usually those clips, the metal clips that are embedded in dentures, they are gold plated, so they don't give that silvery grayish color of the denture. So the denture looks more natural because we don't have that metal showing through. All right. So for the mandibular overdentures, we start with the same procedure, fabricating a custom tray as presented before. And again, it's indicated to use an open tray custom impression. And then to fabricate the master cast using the analogs, okay? And then we fabricate the record base and the occlusal rim. Now, the record base and the occlusal rim for mandibular overdenture for implant-retained cases are the same requirements as the record base and wax rim for a regular mandibular denture. All right. Again, after we have the occlusal rim done, it's sent to the dentist for try-in and for taking up the measurements. And then it's sent back to us, and then we're ready to mount the case and set up the teeth. Once we have the teeth set up in wax, we send out the dentures for a try-in to the dentist, and the dentist gives us approval or not to continue with processing the dentures. When we process the dentures, always make sure that we embed those encapsulators for the clip, so they're going to be processed into the denture, because that's the retention element for the bar. All right, so this is how the try-in it's done. So the dentures is put in the patients, it sees if it sits properly in the bar that's inserted into the patient's mouth, and if the abutments are fabricated correctly. Okay, and and then the denture is processed. In certain cases, especially for maxillary overdentures, some treatment might require additional surgeries, such as sinus lift, right? Also might require a different type of implants used for retention, all right? So sometimes we may need implants that are, because of the bone is shrink, it's reduced, right? We may not be able to use implants that are longer or wider, right? So this is the oral surgeon who decides what type of implants should be placed based on the quality of the bone. And also we have to be careful that the maxillary arch might be considered a five-sided arch consisting of incisors, the bilateral canines, and the posterior region. So where the implants can be placed, it's based also on those areas where it's ideal to place an implant, because we want also to have stability of the prosthesis, and especially to provide stability if the prosthesis have a large cantilever area. Splitting three adjacent sides together result in a rigid structure: central um, and lateral incisor, canines, and posterior regions. So this is how sometimes uh, implants may be placed, and also the fabrication of the bar has to take this in consideration. So there are three typical dental arch forms for the maxilla, which are square, ovoid, and tapering. And for each one of them, there are different treatment options. So treatment option 1, A and B. In a dental square arch form, the incisors are not cantilevered from the canine position. Canine implants are splinted to posterior region and are often sufficient to support the prosthesis. Treatment number 2, A and B. The ovoid dental arch form often requires 3 anterior implants, so both on the canine and the incisor. Splinted posterior implants for a fixed prosthesis. So all this presented up till now, there are good treatment options for fixed prosthesis. Treatment number 3, A, B, and A tapering dental arch form might require 4 implants in the premaxilla, so both in the canine area, 2 incisors in the incisor area, split it together with posterior implants for fixed prosthesis. So the ideal segment implant positioning for a maxillary edentulous arch include at least one central incisor position, both the canines position, both the second premolars, and both distal where the first molar should be, or the second molar. When 10 implants are used for patients with higher force factor or poor bone density, additional implants are planned in the distal half of the second molar position to improve the arch form and to increase the support for the cantilever part of the denture. The disadvantages of 10 implants is the additional cost for the second molar implant and restoration. Many patients do not display the second molar, so it doesn't require this to be functional. So usually, as a rule, when we fabricate a prosthesis, full arch prosthesis, we extend that prosthesis to the first molar. Very rarely when we add the second molar, unless there is enough support for a posterior implant and the cantilever area on the posterior is very small. Only two treatment options are available for the maxillary implant overdentures, where for the mandibular there are five. Okay, the difference is due primarily to the biomechanical disadvantages of the maxilla compared with the mandible. Independent implants and cantilever bar usually are not recommended because of the bone quality. So on the maxilla, we have to remember that by nature the bone is more porous, and if the patient loses bone, that increases the instability of the prosthesis. Maxillary implant overdenture option 1. The first treatment option for a completely dentaless maxilla has 4 to 6 implants, of which at least 3 are positioned in the premaxillar implant. And more important also are the implant sizes and the length. Okay, so for the maxilla, it's very important to use implant from clinical aspect, an implant that has a good length that allows for the process of integration, and also the width of the implant, because that gives more stability of the prosthesis. The key implants are positioned in the canine area, and when possible at least one incisal by the central um, incisal it's suggested. Other secondary implants might be placed in the first premolar region. The implants are splitted together with a rigid bar. The bar is not cantilever distal and should follow the dental arch from slightly lingual to the maxillar anterior teeth. The prosthesis should have at least two directions of movement. So the prosthesis has to have a little bit of movement um, for allowing the transfer of the forces when the patient bites down. Hence, a hide bar clip is used and it's placed in the center of the arch and perpendicular to the midline. The denture is designed exactly as the complete denture, with fully extended palate and flanges, and should be allowed to move slightly in the incisal, so anterior region, during function to rotate towards the posterior soft tissue. Option 2. In the second option for the maxillary implant overdenture, 7 to 10 implants support restoration, which is a rigid during function. This option is the most common treatment because it maintains greater bone volume and provides improved security and confidence to the patient. And mostly it provides stability of the prosthesis. Many patients desire a fixed restoration in the maxilla. The maxillary overdenture should be removed during sleep to prevent nocturnal parafunction. And that's very important. The patient has to be instructed to remove the overdenture during sleep uh, because that interferes with the temporomandibular joint. Sometimes wearing dentures overnight, we don't patient doesn't have control of the movement, and like we said, some overdentures they might have a little bit of movement or rotation into the hide bar, so that could put a lot of pressure or force on the implants, or also may lead to broken teeth in dentures or other problems. So it's indicated for dentures for um, patients to remove the dentures when they sleep. Unlike the mandibula, the maxillary lip often requires additional support as a consequence of bone loss. So that has to do with the design of the denture. Sometimes we may need to compensate for the lip um, collapse by making the denture a little bit bulky in the front for the anterior position. An ideal high lip line exposes the interdental papilla between the anterior teeth. Overdentures replace the hard and soft tissue more easily than attempting to do this with bone and soft tissue or porcelain to metal restoration. In other words, from aesthetic point of view, if the patient has drastic bone and tissue resorption, um, overdenture gives more aesthetics and it's easier to achieve because the way we set up the teeth, we can expose more of the tooth, or we can bring the gum of the denture a little lower so it looks more natural, which is harder to achieve in a fixed prosthesis. Hence, the completely implant-supported overdenture require the same number and position of implants as a fixed restoration. Hence, sinus grafts and anterior implants usually are indicated whether the restoration is fixed or removable. So those are the clinical aspects that usually the doctor has to deal with, but it's good for us to know a little bit about the clinical aspects and to understand why the doctors sometimes make decisions to place implant in a certain position that maybe be detrimental to the fabrication of our prosthesis, but on the other hand, from the clinical aspect, provides success and long-lasting life of the implants. All right, and that concludes our presentation.